Welcome, comrades. NEC Miller officially opened the National Executive Committee, NEC, MidWinter Conference here in Richmond, Virginia. NEC Miller serves from the District of Columbia as your primary NEC representative for District 6 from 2024 through 2026. Comrade Jorge Cruz from Puerto Rico is alternate NEC, serving from 2024 to 2026.
We're going to go ahead and get started again. Our next speaker is from the Department of Veteran Affairs. He's the current executive director for the Richmond VA Medical Center. J. Ronald Johnson provides executive leadership in over 4,100 employees of an accredited health care system that includes a 119-bed surgical hospital, 68-bed spinal cord injury center, 42-bed community living center, 22-bed inpatient mental health unit, 20-bed polytrauma unit, 16-bed domiciliary, 9-bed hospice, related inpatient and outpatient ancillary services, and 6 community-based outpatient clinics. Annually, the system serves over 80,000 veterans in 52 cities and counties in the Central Virginia and North Central North Carolina on a budget exceeding $1 billion with a B dollars. Previously, Mr. Johnson served as the executive director, Hampton, Virginia. During his tenure, the healthcare system opened a 25,000 square feet outpatient mental health building, a 25,000 square feet primary and specialty care outpatient center, and 16 single patient rooms for spinal cord injury patients in an immediate care clinic. Mr. Johnson also served as executive director, Grand Staff, VA Medical Center, Spokane, Washington. During his tenure, he was recognized twice by national leadership as one of the fastest improved VA hospitals in healthcare quality, while improving from 81st to the 14th best places to work. Mr. Johnson has held other positions in the U.S. Army Medical Command, South Texas Veterans Healthcare System, VISN-10, and a VA Central Office. He also served 4 years on VHA's Graduate Healthcare Administration Training Program Board, where he oversaw the Administrative Resident Fellow Training Program, the Health System Specialist Training Program, and Executive Mental Health MAH off campus. Mr. Johnson is a fellow in the American College of Healthcare Executives and was awarded the U.S. Army Baylor 2022 Dean Tolan Preceptor of the Year Award, the 2007 Champion of TRICARE Award, the first VA employee bestowed that honor. He was selected as the VA, there's an acronym, ACHE, and I'm sure he'll share with you what that acronym is, Regents 2006 Young Healthcare Executive of the Year. Prior to starting his career in health administration, Mr. Johnson served, you'll like this, some of you. I know I do. Prior to starting his career in health administration, Mr. Johnson served in the United States Army with the 1st Infantry Division, Big Red 1. Ladies and gentlemen, please join me in welcoming Mr. J. Ronald Johnson.
I can see that I need to shorten my bio. All right. Hey, it's great to be here today.
Thank you.
I know you're a little behind schedule, so I'm going to try to keep you on schedule. All right, I'll do my best. And John's going to come speak after me, and I don't want to take his time away. So I'll try to keep my comments within the time allotted. I believe we have until 11:15. Is that what your agenda says?
Yes.
Okay. And I'll try to allow 5 minutes for questions. If you want to talk to me afterward, that's totally fine. So at the outset, I just want to say that I am a healthcare administrator, and I oversee a very large healthcare system for VA. So I can't answer benefit questions, and I can't answer memorial affair questions, but I can help answer healthcare questions. So as you ask me questions, please keep that in mind. But I can certainly point you to folks who can help you if you have other challenges outside of healthcare. I also want to let you know that I brought some resources with me. I'm not going to talk a lot about the PACT Act, but I do want to let you know that there are resources up here that you can take back with you regarding the PACT Act. So at this point, we as a healthcare system and VA are serving more veterans than ever before in the history of the VA. So Congress has expanded eligibility, and veterans are responding. The PACT Act, when you go back and read it, Congress gave the VA about 10 years to implement it. And I believe the intent behind that was to not overwhelm the VA healthcare system or the benefit system. Okay? So, as you know, Vietnam veterans are getting older, and over the next 10 years, you know, like all of us, we'll get older, some of us will pass away. Korean War veterans, the same, and then you look at the early global war on terrorism, those veterans are getting older. But I think Congress was thinking, as veterans depart the system, because they get older, they pass away, new veterans will come in behind them. And that way we'll have stability within the system without overwhelming the system. And again, that's my interpretation of the law and the way it was written. The way the secretary and the undersecretary decided to roll it out was much different. They said, okay, the law is passed. We're going to get everyone who's eligible under this law into the VA now. So instead of taking a 10-year approach that Congress had authorized, they took a now approach. Okay? And that has overwhelmed the system. So you're probably, the veterans that you're representing are probably experiencing some challenges getting their benefits approved and getting access to VA health care. And it's really the result of good intentions. The secretary and the undersecretary trying to roll out benefits to eligible veterans as quickly as possible. And I think that's a good thing. The downside to that is we're not prepared, okay? And a lot of the care that will be delivered to veterans as a result of that will actually be community care. And Congress has expanded community care eligibility as well to help absorb some of the demand that's coming. So we've seen our community care budgets grow exponentially to the point where Congress is extremely concerned about how much care is going out into the community. We are concerned as healthcare administrators and healthcare providers that more care is going out into the community because it creates challenges for us. Unlike other healthcare systems or hospital systems in this country, those CEOs can focus solely on running that hospital, focus solely on running the healthcare system. And it's typically a medical surgical hospital, or it's a mental health hospital, or it's a spinal cord injury hospital or a cardiology hospital. they come up with niches, what we call niches or niches, depending on which part of the country you're from, and they really focus in on specific services. So they become very efficient at it and cost effective to what? Maximize their profit. No healthcare system will build a healthcare system like the VA, where you have, as you heard, inpatient medical surgical beds, spinal cord injury center, polytrauma center, nursing home, and on and on and on. Okay? It's a blessing to veterans to have us develop a healthcare system like this because we have one record and our providers can refer you within the same healthcare system and your record follows you. As soon as you go out into the community, there's a breakdown. You might recall that early on, as they were expanding community care providers were complaining that it took a long time to get paid. Okay? And there was some truth in that, because VA, again, is designed as a healthcare system, not designed as a bill payer or an insurance company, right? So we had to build the infrastructure. The secretary at the time, Secretary Shulkin, decided to waive the payment requirement, okay? Meaning that providers could get paid as soon as they provided the service. Not did the providers send the information back to the VA. So now providers get paid quickly, but we don't get the information back quickly. So we've had instances where we've sent cancer patients out, potential cancer patients out, to get MRIs, to get mammograms, and there's delays in care. And sometimes we don't get the x-ray results back for 6 months. And guess what? There's a cancer that's been identified. So who wants to wait 6 months for that? To be told that, hey, you have a cancer, right? That's the downside to community care. And it's a significant challenge for us. We are doing our best to hire a lot of staff to pick up the phone and call these providers every single day. The downside to that is what?
They've been paid.
Yeah.
They don't care.
They don't care, and they get mad when you keep calling, and then they just drop out of the network. Because if you're just gonna keep harassing me, I don't wanna be part of your network, right? So, we're trying to build our internal capacity as quickly as we can. You heard in the bio, when I was in Hampton, we opened up a 25,000 square foot mental health building, a 25,000 square foot outpatient center. That's not by accident. The reason those buildings are 25,000 square feet is because of the way funding comes into VA. And I don't want to get into the technicalities too much, but to keep it simple, we have 3 funding mechanisms for construction. We have non-recurring maintenance, and that's the budget, the color of money that we get to paint the walls, repair holes in the walls, and just make sure that we keep our facilities up. And then they have a minor program, construction program. And that has been capped for years at $10 million. Now it's gone up to $20 million. So these programs, these projects, the 25,000 square foot projects, that's what we could build for $10 million. So that's what we did. Do we need more space than that? Yes. But then if you want to go above the minor program, it's called the major program, and now you're competing with the biggest projects in the country. So if you have let's say you need 35,000 square feet, it'll cost you $18 million. Well, you're competing against a hospital that costs $1 billion. And that's, Orlando got a new hospital, New Orleans got a new hospital, Louisville is now getting a new hospital. So there's a big gap between the minor program and the major program. How do you go from $20 million to over $1 billion? You gotta have something in between, or raise the ceiling on the minor program. So construction costs are just going crazy. So right now, the cap is $20 million for the minor program, but they don't like us to submit projects for more than $16 million, because if there are cost overruns, there's a $4 million gap there. You can't design probably more than 12 or 15,000 square feet today for $16 million. So we're not getting the facilities that we need as quickly as we need them because of the way the laws are set up. So if you have some influence on construction and the way the construction budgets are set up, I would encourage you to talk to your senators and congressmen about it, because it's inhibiting our ability to put resources on the ground for you, to keep you within the four walls of the VA. And as a result, it's going to push more care out to the community. Now, you could argue that, well, maybe that's the strategy, right? There are some people who say, you know, that's what Congress wants. That's what veterans want. They want to be out in the community. I don't think that's true. And you can tell me if that's true. I think on a case-by-case basis, there are veterans who would prefer community care. But on the whole, I hear from you guys every single day, guys and ladies, how much you appreciate the VA. Currently, in Richmond for the Central Virginia VA healthcare system, and we go from west in Charlottesville, north up to Fredericksburg, east right before Williamsburg, and south down to the North Carolina-Virginia border. We have the highest quality scores we've ever had. We have the highest trust scores we've ever had. Trust scores come from you. And we have the highest best place to work scores we've ever had. Okay? Why do I mention that? Because you want to know that you're accessing a system that provides quality care, that you can trust, and where our employees are engaged, right? So that's what I'm focused on, those three things. And we have made significant improvements since I've been here, since 2019. And we'll continue to get better. I really think as a group, you have a lot of political influence, and Congress does pay attention to what you say, that, you know, obviously you make your wishes known, but my wish for you would be to continue to support the VA the way we need to be supported. Because if we don't get proper support, the system will kind of start to atrophy. Like, I don't get enough money to keep my walls painted. I can get money to build a new building, but do I get enough money to make sure the floors stay clean and the walls stay painted and things like that? That becomes a challenge. So it's the way money gets allocated, it's the way they, you know, Congress views the VA, and I know it's getting very, very expensive. The healthcare benefit for veterans is the most expensive benefit you have. A typical inpatient stay, mental health inpatient stay today costs over $45,000. Okay? So that's just one example. I mean, if you're getting hip replacements and knee replacements and other things, you're talking tens of thousands of dollars. That's a very significant benefit. Healthcare providers are getting paid more than they've ever been paid. And they can't get paid as much as they get paid in the private sector. Okay, there are laws against that. We are not allowed to be a pay leader, and we have caps. So for years and years and years, physicians cannot make more than the President of the United States, which is $400,000. Okay? Most specialists today in this country are making $400 to $1.2 million. So we're at the bottom of the pay scale. We're not competitive. So if I'm going to maintain my heart transplant program, the liver transplant program, kidney transplant, the cardiac services, we need more leeway. We need more flexibility in the law to pay providers. There are 5 million healthcare vacancies in the United States today. That's not a VA statistic, that's a national statistic. So what does the private sector do in a capitalistic market? Pay more. Pay more. And we don't have the ability to do that necessarily. I have some flexibilities, and I am making adjustments to pay when I can, but what does that do to my budget? See, it just drives it up, and it makes care more expensive, which means Congress needs to respond accordingly. And so yes, is VA healthcare getting more expensive? Absolutely. We have techs today. These are folks who have 2-year degrees, could be 4-year, it's fine, who can make $150,000. That's a tech, a technician. You know, you have doctors, you have nurses, and you have technicians, right? So from, you know, in terms of education and where they are on the hierarchy, they're at the bottom, and they're getting paid 6 figures. Okay, imagine that. I mean, that's a lot of money to have somebody sit there and watch a machine during the surgery. Okay, so I share that with you because you're probably going to get pushback from Congress about how much money continues to be allocated to VA, how expensive it's getting. There's a lot of dynamics at play, including the number of vacancies in the private sector, which is driving up cost. Now, if you notice, the private sector, while they are paying more money to recruit these folks, they're shutting down facilities.
Yeah.
Every day in the industry news, I see another hospital is closed. And they're closing in rural markets first, right? Because that's their lowest profit margins. So rural veterans, rural citizens of this country are going to be even more challenged to get health care within their communities. And that means they're going to have to travel. And if they're going to travel, they're going to travel to us. We need to be prepared to take them on. We need to be prepared to put telehealth options in place. VA right now is working a lot on artificial intelligence. And it's kind of scary to some, and I don't want to scare anyone, but we are working with Amazon as an example. And Amazon has a technology, it's called ambient listening. We can put a microphone in an exam room and it will pick up your conversation with the provider. And the artificial intelligence can distinguish between the provider, the patient, and the caregiver, the nurse, whoever walks in the room. And it knows who's talking. And if the doctor says, I'm going to prescribe you 2 aspirin a day for the next 10 days, it can pick up that and put it into the prescription part of our medical record to get the order started. So this is an example of how we're going to leverage artificial intelligence. Veteran suicide, very important issue for us. Over 6,000 veterans are committing suicide every single year. And we want to get that number way down. This is a challenge for DOD as well. They want to get that number down. And so we are now supporting, this is all groundbreaking new stuff, to perhaps incorporate artificial intelligence to detect when somebody might be suicidal. So we have veterans, very sad stories. I had a veteran recently, a Vietnam veteran, came into the hospital. By all accounts, he's fine. Never really had any significant mental health issues. So he's in for a surgery, has a basic surgery done. But if you're ever an inpatient in a VA facility, when you get admitted, we're going to ask you a series of suicidal questions. And when you get discharged, we're going to ask you again. That's just part of our practice now, because we're trying to prevent veteran suicide. So veteran came in, no suicidal ideation. Veteran discharged, no suicidal ideation. He goes home, talks to his family about what they're going to do over the weekend, and all the plans. That night he commits suicide. No signs at all, at all. So we want to leverage artificial intelligence to be able to detect voice inflection and other things to help our providers identify when a veteran may be, I guess lying is a strong word, but maybe they don't want to come forward and admit that they're going through a challenging time, or they may be contemplating suicide. So that may be coming to us as well. So you're going to see a lot of innovation happen over the next 10 years. We're going to try to leverage technology to help our providers, because there's a shortage of providers. We've got to figure out a way to be more efficient, but we are also very focused on you as our patients, and we want to make sure that you're getting the best care that you can. So I'll just end my comments and I'll let you ask a couple questions. Know that VA is the healthcare system in the country that produces the best outcomes. 2 books have been written about it, The Best Care Everywhere and The Best Care Anywhere. That was written by an investigative journalist, Philip Longman, who asked the question, which healthcare system in the country has the best outcomes? And so immediately you might think of Johns Hopkins, the Mayo Clinic, the Cleveland Clinic, and on and on. It's the VA, okay? So you are getting care in a system that provides the best health outcomes. Does that mean we get it right every single time? No. Okay. Customer service. When we started measuring the trust score, it was in the 50s and 60s. You guys are saying we don't trust the VA at all. So I laid down a challenge in our healthcare system, the Central VA's healthcare system, to be at 92% or above every single month. And it's taken 5 years to get there, but we did it this past year. We hit 92% 4 times last year, 4 months. And the last quarter of the year, July, August, and September, we hit it all 3 months. The first time in our history, we were at 92% or above. And this fiscal year, in October, November, now we're in December, we've been at over 92%. So now we're maintaining, okay? So now I'm gonna set a new goal, 93. But we don't do that by accident, it's intentional. We wanna fix our phone system. We wanna fix our appointment system. We want to provide high quality care. We want you to get great customer service. And when we don't get that right, I wanna hear from you. And a lot of you are vocal enough and you will come to me and tell me, hey, you're not getting this right. Please get it fixed, and I will, okay? So I'm proud to serve. I don't talk a lot about my experience in the military or my family's experience, but my brothers served along with me. One was a Marine, one was in the Air Force. They both retired out of the military. My father served, grandfather served, my wife's family served. There's a lot of personal reasons for me to get this right, because I'm right there with you. I'm a patient of our healthcare system. I want to make sure that even after I leave, that this system is set up for success. And not because of me, not because of my wife, who also served, but because of you, our veterans. So, any questions? Yes, ma'am.
Yes, I had a question about when you were speaking on AI. Do you think that AI would be enough to pick up on inflections of the voice?
Yes.
So
there's already technology out there. They've already prototyped it, and it has 80 to 90% accuracy.
Okay.
So I'm not a technology person, and I'm going to explain this totally wrong. But the way, as I'm learning about it, is the way I'm understanding this artificial intelligence is that they are developing caches of knowledge. So they'll have a bucket. They'll have a bucket that is focused specifically on voice inflection and other things for suicide prevention. And so, they'll take calls from the National Suicide Hotline and they'll analyze them. They'll take calls from other places and analyze it, and then they start creating this database.
Oh, okay.
And then you can pick up that database and use it in an app that you're building. So it's, not only can the VA pick it up and start to use it, other programs can pick it up and start to use it.
So basically they condense it into files and they take all the information they learn from other places?
There you go.
See, the only reason I
You must be IT.
Oh, no. The only reason I asked that though is because I was looking at, I couldn't remember the word I was trying to say, use specifically for it, but there's people that are undiagnosed, but they show I can't pronounce this word, but it says a condition where individuals struggle to identify, express, and understand their own emotions, essentially appearing emotionally detached or flat to others. So the only reason I asked if they could pick up on inflection is because sometimes when people speak, even when you talk to somebody, you can tell from facial recognitions how they feel if you pick up on certain cues or social cues. But if they already have undiagnosed predescriptions of who they are, how could they pick up on inflections in a voice if they already are stoic? Like if you already are in that space where you don't even give an emotion when you speak, how would AI be able to pick up on an emotion that they wouldn't be able to encounter?
One of the challenges that we'll have. This is all brand new science. It's something that the VA has a strong interest in, but it's not perfect today.
Okay.
This will be something that will be developed over the next 10 years.
So will they be doing like how they normally do trials for stuff? So like they have like condensed communities where they do like 10 people, 50 people at a time, and they ask the same questions and they kind of see what answers they have? Okay, that makes sense.
Yeah. They'll get down to the basic research model for that. Yes, sir.
2 years ago, I went to the emergency room, and first I went to my primary care physician, and I didn't feel comfortable with the response that he gave me. So he said by the time I could get another appointment, he didn't know what the situation would be. So I ended up going to the emergency room at Centera. I just saw the receipt or the bill where the VA paid. It was over $7,000 for that one visit. My question is, when I was there, they asked me, did I have any testing done at the VA, which I did. He ordered a whole series of tests. So when you were mentioning about them not getting the information back to the VA in a more efficient way, while I was there, when I told him I had the test done, he asked me, did I know what the results were? Thankfully, I had the My Health or Healthy Bed thing, and I was able to pull up my test results from the VA. And he was able to use that in order to diagnose what my situation was, which was great. So my question to you is, when they say Centera or community healthcare, are they not able to access that information back to the VA? I'm not understanding why it would take so long for a community healthcare provider to get the information to the VA in the length of time that you were saying when I had it right there. Even though it wasn't coming from Centera, I'm just saying, does it work in reverse? Is there a way that the community healthcare providers can get that information back sooner?
There's something called the Joint Legacy Viewer. The VA has implemented. Providers, if a community provider opts in, then we have access to certain pieces of information, not necessarily the entire record. So that helps. When it comes to radiology specifically, that is a bigger challenge because you can't really see the images the way you need to, and providers aren't putting their notes in the way they need to. So yes, does the technology exist? It does. Does everyone participate? No. And does it always work the way it should? No. It's very slow. Our providers prefer not to have to log in and try to seek out that information because it takes a really long time. So yes, the technology is getting better. More providers are participating. It's just not where it needs to be efficient.
Yeah, because I can see where that would definitely be a very cost-heavy situation, because if, say, Centera ordered those same tests that I
Yes.
just had the week before, and then the VA's paying for it, it's like double dipping practically. You're
Yes,
paying
that's
for the
right.
same test twice, when if they were communicating, more efficiently, it would have saved the VA money for that.
Absolutely. That's right. No, you're exactly right. Other questions? Go ahead. I can tell you now.
Okay, and I do have a question. So is your plan to, create more spaces, like more hospitals, more buildings that are incorporating like specific, like problems that people may have?
Yeah, so we are currently getting ready to open up a new 10-bed unit in our CLC, Community Living Center, for veterans who have long-term care needs, but they struggle with dementia and Alzheimer's, and that results in behavior problems. So this will be a locked unit where we can keep them safe. So that's one example. We're also getting ready to open up a brand new clinic in Fredericksburg. 471,000 square feet. It's bigger than 10 VA campuses, VA's inventory. And those are hospitals, by the way. So
I also have one more question.
Yeah.
Okay, so, I know that, the VA has facilities for specifically for medical, situations or medical, instances. But since a big part of like what we do at the DAV is like sponsored for veterans that are homeless and stuff like that, is there any like chance that the VA or it would be a subset for it to create a space for people that are homeless, like to decrease the homelessness?
That's
or?
not the plan today. I mean, the plan today is to get veterans integrated in the community. So when our homeless staff are working with homeless veterans, they're trying to figure out how to get them housing where they are versus trying to bring them into an institution. So the thought is there, how do we help our homeless veterans? The model is just slightly different than what you're suggesting.
Okay, well see, because when I think about it, I wasn't necessarily thinking more like institutionalized as far as homes, but like, how they're kind of building up in Norfolk, like different communities, so they've been tearing down a lot of the, I would like to say projects, subsidized housing. So they've been tearing down a lot of those housings and building up public housing, and then they're making the price exponentially higher, creating more places for people that essentially make more money to go. So I wasn't necessarily saying it had to be an institutionalized space, but why wouldn't they create a space or an environment for people that didn't have the housing that we already had a problem with, that were homeless, to be housed
So you
in
can,
the same way?
yeah, you can Google some foundations that are trying to do this work right now, and they're developing small veteran communities. They look like little, they're just mini homes, little small homes, and they're building them in a kind of
Like a cul-de-sac kind of?
cul-de-sac type fashion.
Yeah, cause I know they have some already, like for people
Right.
that are necessarily like still in the military, they have military housing, so they have houses that are kind of based and arranged the same way, or like built in the same structure. But I definitely was interested in like why that hasn't been implemented as like a plan of structure, since they are doing it for people that are already institutionalized as far as mentally.
Yeah, I think if you Google it, you might find a group in Virginia that's doing the work.
This couple of them is doing it already.
Yeah,
Oh,
and maybe you could join them, right?
Subcontractors.
subcontract?
So I'll just leave you with this, and I'll be out here if you want to come talk to me a little bit more. Has anyone ever heard of Michael Rod Rodriguez? He is the CEO of the Global War on Terrorism Foundation. Okay? So he is working very diligently to get a monument built in Washington, D.C. For those who served during the Global War on Terrorism. But I got an opportunity to hear him speak recently, and he comes from a long line of veterans himself. And when he made the decision to join the military, his dad pulled him aside and said, you know, son, I didn't really ever want you to serve. Because when you serve and the experiences that you go through, it will change you. And those experiences will be with you for the rest of your life. So from that perspective, as a father, I didn't want to see you ever go through that. But if you made the decision to serve, then my piece of advice to you is this: do more. Don't do your best, because your best has limitations. You're going to get to a point where things get very frustrating, so you stop. And then you tell yourself, well, I did my best. Things become so painful that you don't want to push through. So you tell yourself, I'm going to stop now because I've done my best. Don't do your best, just do more. And so he adopted that philosophy, and he carries that with him today. This was life-changing advice. He deployed 10 times, and received some significant injuries as a result of his service. Received a Purple Heart, other medals, and now he continues to fight for veterans. And that's why he has this foundation. He's really pushing to get a monument up for veterans who served. But I want to tell you that when I heard that, it changed the way I thought about leadership. It changed the way that I push our employees. Because we can always do more. We can always push through. We have a lot of challenges, right? And it's very easy to succumb to the challenges, because it's a lot easier to throw up your hands and say the bureaucracy's too big, the laws are too tough, these things don't make sense, and I don't have the power to change anything, so I'm just going to accept it. And if you ever catch yourself in that moment, remind yourself that you can do more. So I'm going to remind my staff that they can do more. I'm going to remind myself that I can do more. And I'm going to do everything I can to create the healthcare system that you deserve and that you've earned. So thank you for allowing me to speak to you today. And I really do appreciate coming out and having a chat with you. And I really honestly appreciate your support. My last ask is this. We're going to get some more vans, it sounds like. And I need drivers. So think about that. You do have to go through a physical, and that takes a little bit of time. But if you're willing to do it, We'd like to have some vans running in the Richmond market and the Fredericksburg market early sometime next year. If you're willing or know people who are willing, we'd be happy to accept you as volunteers. So thanks for all you do on behalf of veterans, and it's been my pleasure speaking with you today.